Just because you arrive at the hospital in an ambulance stretcher doesn't
Um,
mean you're going to get seen faster.
and you
That is absolutely not true whatsoever. It's just straight up not true.
really,
The ER is going to triage everybody.
so they don't have a room for you already. If
No, yeah, they don't have rooms ready for us at all.
All right, man. So we're back with Rick Torres. We were talking about his role as a firefighter. Now we're gonna go into his role again, but this time as a paramedic, right? So I see here that you have 2 years under your belt as a paramedic, but you've been in EMS longer, right? Because you were an EMT.
Yeah, I started back at about 10 years in EMS as well, just the same as fire. When I got hired after I finished the academy, it was with Weslaco Fire Department, and they do fire EMS. I didn't know that at the time. I was just applying at different places
Okay.
to trying to get hired, right? I mean,
Yeah.
I just wanted to start somewhere. So when I got hired, I was like, sweet. And they're like, oh, by the way, we do fire EMS, so you're gonna need to go get your EMT, your basic at least. So I was like, all right, cool, for sure, let's do it. And so like right off that, I started with my EMS side, running 911
So
because
that's why you did the EMS part because it was this part of the job.
pretty much it kind of pushed me into it. I grew to love it, definitely. But initially it was just like, all right, cool. I mean, this is part of the job and I'll do it.
But why? So why basic to paramedic though? Because you still climbed the ladder.
Yeah. So I guess running on the box, I got my feet wet. Like, okay, cool. Simple little stuff, taking blood pressures, simple vitals.
Mm-hmm.
But then seeing what the paramedics were doing, like all the medication administration, starting IVs, intubating, a bunch of stuff like that. I was like, man, that's pretty cool. I think I could do that. So that was kind of like the incentive. I got my intermediate after that because it goes basic, intermediate, and then paramedic. And so I got my intermediate after that. Kind of opens up the interventions that you can do a little bit more, starting IVs, certain medications. And then I had started my paramedic course back in 2016. I didn't get to finish due to some personal stuff with life and stuff. But that at that point, I switched also departments and I started working in a couple different areas. But recently with work, with the city of Mission, I just completed 5 years there. And I think it was after year 3 that the talks of saying, oh, you know what, let's go fire EMS. Because originally it was just a, traditional fire department.
Mm-hmm.
But due to the city wanting to move in the direction of fire EMS, it was like, okay, well, let's see, can we do it? We started originally with only 3 paramedics that worked within the department, firefighter paramedics. So it was like, okay, if we want to get there, if we want to like run trucks, we're really going to need to like up the amount of people that we have that are eligible to run on the trucks. And so at that point, knowing everything I'd already seen working in fire EMS at Weslaco and then in Palmview, I was like, yeah, if we transition, I definitely want to be a paramedic so I can run my own box, because you get to make all the shot calls, right? And that's your box, whatever patients you get, they're under your care. You got to go, you got to follow your medical director's protocols, but it was one of those things like, I want to make those calls because I feel like I'm ready now at this point. I think at first it's a lot of like liability. I think at first it scared me, or it made me nervous, I guess. But now, yeah, 10 years after, it's like, nah, I'm ready to do this. I'm ready to take it on. And
Because you're dealing with like hardcore drugs, right? Like the stuff you're pushing, like paramedics, like And when you say box, you mean the unit, right? The truck.
yeah, the box.
Yeah.
Yeah, when I say box, I mean the ambulance.
Yeah, yeah.
That's
And as a paramedic, like you're dealing with like some of the big drugs that like doctors use in the ER, right? Because I've seen like not to get like adenosine is one where like you stop the heart to get it going. Like you're doing all that stuff on the scene, right?
yeah. But I
As a
mean,
paramedic.
yeah, the boxes or the ambulances, they're all MICU capable, which is medical intensive care unit, right?
Yeah.
So we can do almost everything that they do in the ER, man. It's just in a micro, smaller, setting. But yeah, all the drugs that they push in there for the most part are all the same. Adenosine. We have the paralytics because we have RSI. We have
What's RSI?
a rapid sequence intubation. So basically, you gotta for whatever reason the person isn't able to maintain their own airway, or you see them on that decline, you basically have to paralyze them, set up an airway in them, and then keep them sedated.
Dang.
Yeah, so it's a process. You got to sedate them first, because you can't just paralyze them without sedating them. That would be unethical.
Yeah. Yeah.
You think about it. Yeah, yeah, because they'd still be feeling everything. So you got to sedate them, put them to sleep first.
That's crazy, man.
And then you go ahead and you paralyze them, establish the airway, and then just, ventilate them all the way till you get to
And
the
you do like
hospital.
little procedures too, right? Like where you like puncture the hole, like a thoracentesis, like that.
For like darting somebody.
Yeah, that kind of stuff.
Mm-hmm.
Okay,
For sure.
man.
For any type of like pneumothorax.
Yeah,
pneumos. Yeah, definitely. There's some paramedics that do finger thoracotomies, where they do the incision on the side and then they open it up, just so that way they can get some that negative pressure build up. Yeah.
Man, dude, that's crazy. So and that's cool, because like I think a lot of us, like when we hear paramedic,
Taxi driver.
kind of, like I don't think the profession is respected, man. Or like I don't think we realize like how serious, or like the weight, or like the even like the power, or that a paramedic has. Like there's a lot of stuff that the nurse can't even do at the hospital, that the paramedic has already done 10 minutes ago on the scene, like at the football game or something.
Yeah.
Like there's a lot. I can't think of I guess the autonomy, right? There's like so much power, I guess, that you have, that it's a pretty legit job, man. It gets a bad rap, like it's like one of the dirty jobs and all that kind of stuff.
Yeah.
But dude, like, let me ask you this: do you have any like any crazy stories with during your time with EMS?
Yeah, man.
I can imagine, but like, what have you seen?
I think in EMS you see even more on the fire side, because you have to deal with these patients all the way till you get to the hospital.
Okay, you don't hand off that quick. Yeah.
Well, I mean, you do got to hand them off, but even then,
it takes longer. Yeah.
Everything and anything, man. It's kind of hard to pinpoint. I've had like crazy psych patients who do crazy things. I've had some pretty bad trauma calls, gunshot wounds, a handful of cardiac arrests.
Any memorable stories where you're like that one kind of stayed with you?
I guess, I mean, if we're putting it into like generalization of like either like medical or trauma, for trauma, definitely. One of the craziest ones that I had more recently, it was a messed up call. Traumatic brain injury. So we had a lot of trauma to the forehead. And the guy was just completely out of it. He was still conscious to a certain degree, but you could tell, like, the altered mental status was there. And then, so I'm trying to get him into the unit. I'm trying to establish IV so I can push fluid. And so I can hopefully maybe sedate him, put him down, but it was going all over the place. And then he started throwing up blood all over the place. And like, you're looking around the unit and it's just like, it's all over the place. And you're like, man, it gets pretty hectic, but I have really good partners who help me out, control what they need to do. That one, and I got him to the hospital alive, and I think he may have passed away about a week later, just because the ICP, the intracranial pressure, it just couldn't get it to go down. It just kept going, and it kept going. But I mean, with the type of injury that he had, it was pretty crazy.
By the way, I might ask you questions like what certain things mean, definitely. Just because like we as a community don't know
the vernacular. Like, yeah,
we don't know what ICP is.
Yes, if I do.
So just to let you know, because we know each other, so he might be thinking like, you don't know what that is, but just as a little disclaimer.
No, for sure. Yes, please stop me so that way I can explain it a little bit better.
But I really couldn't figure out the RSI. Like I was thinking something else. I was like,
yeah, it's rapid sequence intubation.
No, but yeah, man, and because how do you? Because I think about the stuff you guys deal with, man, and I deal with EMS a lot, like with paramedics and EMTs, and I've dealt with some or not dealt with them, but I've talked to some, and they're like, man, my heart rate's still going from that like cardiac arrest or whatever. How do you keep your composure? in
it,
that kind of deal?
it's weird, man. It's like kind of like we talked about last time about the whole the adrenaline shoots up, and so your senses get hyper focused. It's weird. Like in those moments, there's so much going on. But you're once you've already trained and you continue to train on those different types of like procedures or whatever it is that protocols that you're doing, you just get zoned in and focused. Like I need to take care of this, and like you do like this mental check off as you're going through them. That's usually what I do to the best of my abilities. When it's a chaotic call and there's stuff going like that one, IVs were in, great. All right, I'm going to move over to this now. And then all of a sudden he starts throwing up. It's like, all right, now I got to go to suctioning. And then by that time I told my partner, I was like, dude, let's go. Let's take off already. I'm going to call it into McCann and we'll race over there. I'll do everything that I can. As long as I can maintain his blood pressure, keep that airway patent, then we're good. I can get him there and they'll do whatever it is that they need to do over there at the hospital. But yeah, man, it is definitely a difficult job. I think, like you said earlier, sometimes they get a bad rap or not enough acknowledgement. Not to put nurses down or anything, but yeah, the nurses, I know they have to go through they have to ask the doctor, can I do this? Or they have to wait for the doctor's orders. Okay, go ahead and give him this. Okay, go ahead and give him that. We're under like this umbrella of protocols.
Standing orders.
Yeah, exactly. Where you have to kind of like make those decisions for yourself. And, I've had it where patients have like 3-4 different, signs and symptoms that, do I fix this first? Do I fix that first? What do I do? Like, because each way I go is going to be a different route of treatment and medication. Is this going to make it better? Is this going to make it worse? Or, you know what, let me start with this, fix that, and then I can go to this, fix that, and then I can go to this. So you have to be, really on top of it.
Just you and your partner, right?
And that's the other thing. It's just you and your partner, man. I've gone into the ER, and when they're going to do that, RSI, or they're going to intubate somebody and they're going to put them down, you have a whole team of nurses that come in. They call a trauma alert in this room.
Cold manpower.
Exactly. And you've got like 8 nurses and, LVNs and whoever else is coming in. Then you have the main doctor there. And the doctor's like literally just sitting at the head, and they'll be like, all right, give me this drug. And there's already like a nurse ready and hands it over to them.
Yeah.
And then they push it. All right, give me this. And like they're there. That's not...
You're just watching like,
exactly.
If I had that team.
Exactly.
Dang, I never thought about that.
And in the back of the box, there's no one you can ask. It's like, try to get that IV while I pull this medication real quick. You're pulling it and you're trying to calculate the dose, and you're like, okay, hold up, wait, did we do this? Okay, no, let me put that aside. Go over there real quick. And, it's a lot, man. It's a lot, especially when there's only 2. The good thing, though, in the fire service, though, fire EMS, is that usually when it's a critical call like that, the engine will show up. And when the engine shows up, there's at least a couple of other EMTs, maybe another paramedic, hopefully on that engine, and they'll jump on board and they'll start helping you out. So you have more hands on to help you. So it's a really big team effort that we do there. So you're not always by yourself, but a majority of the time, yeah, you are. It'll just be you and your partner.
So I can imagine the camaraderie there too, right? Like, it's a brotherhood, partnership.
You have to make sure your partner understands, and we train with each other. And so now I've gotten to the point, like I have my partners. It's like they know exactly what I want without having to ask. Like get into the unit, and I say, give me a full run up of the vitals, and they'll start everything, 4 lead, glucose, everything, just so I can make sure everything's good there, and then we'll move on from that. It's good, man. It's a lot of work.
Do you ever and I ask you this because some people like I know this is a big thing for cops, for doctors. Do you talk about work with your friends and family? Like, do you tell them like, oh man, today I had like this trauma? Like,
not really. If they ask, I will. But again, it's...
do you internalize? Like, do you keep that inside to yourself?
For the most part, I share it with my wife because I have to share it with somebody, and I think she understands that now. There's certain stuff that you can keep and hold on to, but it really helps to at least talk about it, get it out there, even with your partner after the call. It just helps. It may not fix anything, but being able to talk about it, it gets it out instead of just keeping those feelings, even just running back the call. Remember when this happened, and it's crazy. We did this and then that happened. just being able to vocalize it helps to, I guess, accept it better because you're putting it out there versus just letting the thoughts run rampant in your mind. Vocalizing it helps a lot.
Do you have anything that you do? Not necessarily like when you lose someone or like something to help you cope with like with it, because it's trauma, man. Like it, like visual emotion. Like it's at the end of the day, it's trauma on you. Do you have anything that you do to like cope with that?
Uh, Music, like you said, certain music, playing music myself. I think that really helps. Um,
But nothing like in the moment or not in the moment, but afterwards.
Directly afterwards, not necessarily. I kind of just replay it in my mind. I think the biggest thing that we do is being able to talk about it. I've really come to terms with if you don't want that trauma to really build up on you, you got to let it out somehow. And so by verbalizing it and talking about it with your partners, we've come to a really good mutual aid of like, you know what, hey, let's talk this out, you know, let's get this out there because holding on to it isn't going to be good for anybody. And there's some guys that they won't talk, they'll keep it to themselves or they'll just listen, and that's fine. But just being in there in that setting of, hey, let's have an after action review, a talk, let's just talk about, you know, what happened, what we did
For the big stuff,
and you know, we'll get through it together. Then the department's really good about that as well. They have different programs that they've brought in before, like therapy dogs. And those yeah, those are really cool. I've always enjoyed them. I love dogs. So
Yeah.
anytime the therapy dog comes in, like they love attention. So they love being hugged and you can grab them and hold them. And the dog will just like, they pull that trauma from you and just being,
You feel it. You feel like
feel it, yeah.
the love.
So it's really cool to see that. And you know, it's interesting that you bring that up, the whole trauma. I was actually watching a TikTok today. And I guess we become so desensitized to it.
That's why I'm asking. Yeah.
We become so desensitized to it because it was about this guy who was at, I think, the EDC in Las Vegas, and they had an overdose victim. And he was talking about it, and the guy's like crying in the video, and I think they Narcaned him. Narcan is a drug that, you know, reverses overdose.
Yeah.
It does that. So, but you could tell, and he was like, it was just so traumatic for them to see this guy going in and out of it and in out of it as they kept trying to Narcan him and bring him back. And I think they did. I think they saved the guy. And I think at the end of it, it was like an ad for Narcan because it saves lives.
Oh, yeah.
But it just goes to show that, you know, these are traumatic events that any normal regular person that's going to come upon it, they're going to be traumatized
Freak
from
out.
it. Exactly. And nowadays, like, I can have 2-3 cardiac arrests in a day, and it's just like, it's
Another
part of
day
the
in the
day.
life.
Exactly. They don't affect me in the same way as they used to, but because you become desensitized to it, you know what I mean?
But that's crazy though, man, because you're not supposed to see that. Like a human being is not supposed to be like, oh, that guy's heart stopped, and like you talk about it, like you move on to the next thing, or like you're ordering Whataburger because it's lunch hour.
Exactly. It's
you know what I mean? Like that's not normal.
It
man.
isn't. It really isn't.
But the weird
normal.
thing is that you don't realize that all the time. Like you don't realize how abnormal your job is.
Yeah.
Like, and I guess that's when you know that you've gotten like acclimated. And the whole desensitization thing, man, it's kind of like a touchy subject because it's like, man, like you don't want to feel, or you don't want to like, you don't want people to think that you're calloused either. But you have to, like, you like for your own sanity, you have to adjust.
Yeah.
And I think that's also, and I know fire and EMS does it and police do it. I've talked about it a little bit. I work in healthcare. I never said what I do or where I work, but one of the things that all of our fields do is that you kind of laugh about stuff. And I personally, man, I used to hate it. Like as a student, I would see like the doctors, EMS, when we would call the ambulance, and a lot of times they're just talking about like, oh, like yeah, like there's this new Chick-fil-A or whatever, you know. Or like at work, you're like you work in the ER, man. You're gonna see like the nurses joking around, the doctors joking around, the firemen, the paramedics. But it's almost like a coping mechanism. Like you have to like to keep yourself like sane.
Yeah.
Right. And that's one thing that I kind of wish that people like would not understand, because you really can't understand it unless you deal with it. But I guess just to know, like it's not, because it can look disrespectful. Like, especially when you show up to a scene and everyone's panicking and you're not, even that can seem disrespectful, because it's like, do you not, like, she's not breathing. Like, do you not realize how serious this is? Like, you're getting your pack, like, you're going through a checklist. Like, what, dude, my mom's not breathing.
Yeah, no, there's definitely a time and place for it.
But you have to keep your
But
sanity at the same
yeah,
time because you're a
no,
human too.
exactly. I mean, you do afterwards, we do tend to laugh about certain calls, and there's calls that are funny
Yeah.
that you run across, silly situations. But yeah, definitely for the traumatic calls, like on scene, we try to keep like our composure with everybody. It's in the moment of the work. It is like let's go to work. Afterwards, behind the ambulance doors, then yeah, we'll go back to the way we cope with it and joke around with it. But it's never in a sense of like disrespect to anybody. It's like you just said, it's our coping mechanism. So that
Right.
way, I mean, the rest of the shift has to go. We still have the entire shift to work. We know that 30 minutes from now we're going to get another call, and that could either be worse or not as bad. So it doesn't end there. We can't just put like the day on pause and be like, I need to get away from this and reflect. Like, I still have to finish the rest of this shift off. I still got
Yeah.
7 more hours to go or whatever it is. So yeah, it's definitely a coping mechanism. Because like you said, we do get desensitized to it, just seeing it so often. And I think it's just why I said earlier, fire, police, nurses, doctors, EMS, you're around death so much that it just becomes something normal to you. It isn't. It definitely isn't. And, when you see, the family go through this traumatic experience, you feel for them. But at the same time, you're just like, this happens. Like, this just happened, 2 days ago somewhere else.
Did you ever have to tell someone that their family member passed away, or is that not your thing?
Uh, yeah, I have. And that one's tough. It takes some time, some practice.
Break the news.
Yeah, you can't lie to them. You can't sugarcoat it.
How's my son doing?
You can't, you can't give them false hope. You just have to be kind of direct, but also, with some empathy. Look, we did everything we could. We tried. Unfortunately, your son just wasn't able to be brought back, or, whoever it was. We tried everything we could. We did all these interventions, and it just, unfortunately, we weren't able to bring him back to life. His heart stopped.
You've had to do that.
Yeah, and you have to be like real clear with that, because you can't be like, oh, they didn't make it. Is not going to be like, you have to be real specific, like their heart stopped, and
Said it.
yeah, so that way they can understand what you're telling them, because
There's no chance.
yeah, exactly. And in those traumatic moments, the mind is trying to grasp onto any little sign of hope, and so if you do that, you're just making it more antagonizing for them.
Yeah.
So that's one of the ones. And then that goes to another protocol that it's a touchy subject, calling codes in the house, because there are certain departments that do that. Like, okay, if we get a cardiac arrest at the house, that's one of the, I guess, things that
calling codes. I get you. Like,
people don't understand.
That means calling the time, like at 12:37.
Yeah, calling
patient expired.
Yeah, exactly. And there's a lot of people who don't understand that part of EMS. I think that's a big issue. People think, oh, why aren't you loading him up? Why aren't you taking off to the hospital? They don't understand that everything that we're doing there on scene is exactly what they're going to do at the hospital. The medications, the interventions, the tube, everything that we're doing there on location with the patient is exactly what they're going to do in the hospital.
As far as life-saving stuff, right?
Exactly.
Yeah.
If it's going to happen there, it'll happen there. If it's going to happen at the hospital, then it'll happen at the hospital.
It's faster there anyway. Right?
Exactly.
You have to move them, and yeah.
One of the biggest thing is a stop in compressions, and
and there are people and families watching, right?
And families watching, and it's hard, right? That's one of the hardest things, because you're working a code inside of a house, you're doing compressions, but if you have to move them to the ambulance, there's a certain pause. And then you're on the ambulance, and doing compressions on the ambulance is not as efficient as in a room where there's nothing moving around you, and you actually get to focus on that, that skill that you're doing. And so all those
it's better to not get in the ambulance.
It really is, but people don't understand that concept. They think, oh, they're just wasting time. Why haven't you taken them yet? Why haven't you taken them yet? And it's a matter of like educating the public that, CPR, what we're doing there, we're doing everything we can to save the patient. If they're going to come back, they're going to come back there. If not, I've had numerous calls where I get to the hospital and the ER doctor asks me, how long have you been working them for? About 40 minutes, doc. All right, call it. And
they didn't do anything.
They didn't do anything. And it happens because they know they respect our profession. Even the word paramedic means besides doctor is
Yeah.
what it means. So they understand that you did everything you could on scene. If you didn't bring them back since now, do they have any type of heart rhythm? No, nothing. Then just call it. If there is a heart rhythm, if they're in like ventricular fibrillation where the heart is still trying to quiver, it may not be pumping, but it's quivering, then we'll continue to try and shock them back into a normal heart rhythm. But if we've done everything we can, there's no heart rhythm, nothing.
Mhm. Yeah,
Numerous times.
that's another thing. Am I correct in saying that, like, because even like the whole like trying measures, because the family's watching at the scene,
Mm-hmm.
like, or sometimes we get upset because we just don't know. Is it true that you can only shock someone if their heart is actually like, if there's a rhythm, like V-fib or something like that?
Yeah.
Because you don't shock asystole, right?
No.
Okay, like you don't shock someone that has no heartbeat.
Yeah. So there's in cardiac arrest, there's four rhythms that can occur in cardiac arrest. You either have asystole, meaning there's like zero electricity in the heart. PEA, which means pulseless electrical activity, meaning there is electrical activity going on, but there's no pulse. It's not actually beating. Like the rhythm's just flowing through, but there's actually not a pulse. You have ventricular fibrillation, where the heart's quivering, but it's doing it so fast that there's no effective pump, or VTAC, where it's like in super super fast, and it's not efficient enough to get a full pump.
To actually
Exactly.
push blood.
Exactly. And it's called VTAC without a pulse. So the only ones that you can shock are VFib and VTAC. That's it. The other two, you can't shock them.
So if I show up, or if you show up to a scene and somebody's literally has no pulse, like there's no reason, you're not gonna shock, right? Like they're just
Oh, well,
you push meds instead. Or?
I'll feel for a pulse, and so you won't feel you won't feel a pulse in VTAC or VFib sometimes. So I still have to put them on the monitor with a defibrillator. It's like a manual defibrillator. It's got two big old pads. You put them on, and then it'll show me the rhythm. And if it's something that I can shock, then I will. And if it's something that I can't, well, then we'll just work it as a normal code. CPR, pushing epi.
And it's the same thing in the ER. They're still not going to shock that either, right?
Exactly. Yeah.
Yeah.
They follow the same ACLS algorithm that we do. It's I think the ACLS, which is
Advanced Cardiac Life
Advanced
Support.
Cardiac Life Support, which is put out by the AHA, which is the American Heart Association. That algorithm is used in the hospital the way it's used in the ambulance. It's the exact same thing, same medications, same interventions, like everything is identical.
Man, that's interesting because even I personally, I remember as a kid, that would bother me. Like, dude, why are you taking so long to get into the hospital? Like, you guys are just talking. But so what you're teaching us is that everything that you're doing is the same thing the doctor's going to do. Well, the only difference really then is that it's going to take the doctor 15 minutes more because you got to get him there.
Exactly.
You're already there.
Exactly.
Wow.
And with CPR, recent studies, a lot of good information has come out where compressions is just so vital. And having very limited interruptions in compressions. That's something that we train on constantly, is effective CPR. What real good compressions looks like. We had the owners of Lateral, they make all those mannequins. Have you seen those like CPR mannequins?
Oh, yeah.
So we had them come in.
Oh, yeah.
And they did a really good training with us a while back. And they kind of showed us like
the green light when you're pushing far enough.
But it shows you. And we came to the realization what we thought was good CPR really wasn't. And so it helped us to like really better ourselves. Like now we fully understand, what good CPR looks like and what it should be like. So in doing that, and they also taught us, look, compressions are like the most valuable thing you can do, and limited interruptions in compressions, because you're getting that blood flowing through the rest of the body. And if there's any chance that they're going to come back, it's because of that. So doing that really helps. But then again, like I said, you go back to that, it's a very delicate protocol, working a code inside of a house and then saying, all right, we've been working this code for 40 minutes. Let's call it. I don't think people down here are ready for that.
Yeah.
Yeah, because I think people would be upset and like, hey, you didn't take him to the hospital. You didn't give him a chance. But it's understanding that everything that I'm going to do right now, right here, is the exact same thing that they're going to do at the hospital.
Beyond that, it's just visual for them, right? For their own like sense of like they tried. It's more like you're doing it for them. Like you already know this. Like it's not
exactly.
Have you ever done that where you're just doing stuff just to show the family that you tried? Like interventions that you know aren't going anywhere?
I mean, we always try right off the bat, right? I mean, it's never where we start and we know that it's not going to work. I've gotten to calls where it's like I know for a fact that
DOA.
yeah, DOA.
Dead on arrival.
I won't attempt, because I'm not going to give them false hope. But if there's a chance that we can, then I will. And then midway through, if I see we're not going anywhere, it's just like, all right, at this point, just for the family sanity, let's load them up. Let's go. But I already know where this is pretty much going.
Yeah, I've had that. I ask you because I've had paramedics tell me that, like, where they've literally done that more for like, because like you're also treating the family. So like in 20 years when they're thinking about when grandpa died, like you're gonna know that like they tried everything they could, and you saw them with your own eyes doing everything, even though the paramedic the whole time you like this isn't gonna go anywhere.
Yeah,
exactly. That's loving though, man. That's really nice because you're like it's a gift to them. Like you're giving them peace of mind in a way later on, because right now they're not gonna feel that.
Yeah,
but
no, for sure.
That's awesome, man.
Yeah, you have to have a lot of empathy in this job too, man. I think that's one of the things that I kind of dislike about the job is that you see a lot of burnt out medics just kind of lose that from this consistency of running on all these calls. Yeah, that they lose that empathy,
bedside manner. They're just real cold.
Exactly, and that's one of those things that you got to keep intact with this job, man. In EMS, like 90% of the calls are going to be silly calls. Is what I call them.
But that's a good thing.
Yeah,
I love the silly thing, man. Like, but that was a silly call.
There's silly calls, or not critical calls. 10% are critical. Like, man, they need a paramedic.
What's critical?
Critical is anything where they need to get intervention quick, or they're gonna end up losing their life.
So like heart stop, bullet like shot, stuff like
gunshot
that.
wounds, GSWs.
We're trying not to.
Gunshot wounds, cardiac arrests, overdoses that are serious,
car accidents, right?
Car accidents where there's major trauma involved. Those are the calls where they definitely need an ambulance. But 80% of the time is my stomach hurts, I want to go to the hospital.
And they call the ambulance for that?
Mm-hmm.
I mean, we're talking about people that have insurance then.
Oh, absolutely.
Because no one's going to call for us to make it.
That or they just don't pay.
But
we do get, our routine calls of my stomach hurts, my leg hurts.
You have frequent flyers?
Mm-hmm. Yeah,
really? So you know people?
Mm-hmm.
From your like work. Like, I know the guy from work, but not because he's a paramedic. Like he's the guy on the stretcher. You have a lot of those people.
We do. We have certain addresses. As soon as we hear the address, we'll be like, "Oh, it's so and so."
Oh, you already know?
Yeah, we know him by name.
It's 121. Yep, Anthony Street.
It's so and so calling. All right, here we go again, and we know what to expect when we get there. And so,
but you have to offer transport, right?
Yeah, we can't refuse anybody.
Yeah.
If they want to go to the hospital, we got to take them.
But you have to offer, like you have to say, like, do you want to go to the hospital? Mm-hmm. Like, yeah. I mean, of course, you can't refuse anyone, but
yeah. So no, we'll get there, and so I'll ask, what's going on. This is what's going on. All right, cool. Gets a little bit brief medical history. All right, so what do you want to do? Do you want to go to the hospital, or do you want to? What is it that you want? Yeah, I want to go to the hospital. All right, great. Which hospital do you want to go to? So when we always leave that in the patient's decision as well.
Yeah, where they want to go.
Yeah. So they'll decide. DHR, admission, whatever it may be.
Okay.
Take them, transport them.
Another question for you, man. Is there anything that paramedics wish the public knew that we just don't?
Yeah, kind of what I just mentioned right now. The whole knowing how much we're actually capable of doing, I think it's underrated. I think a lot of people just think that we're the taxi drivers, that we're just going to put them on the stretcher and take them to the hospital. Oh, and this is another one. Just because you arrive at the hospital in an ambulance stretcher doesn't mean you're going to get seen faster. That is absolutely not true whatsoever.
People stay in the ambulance, right? Like you can be in the ambulance waiting.
Or they'll stay on the stretcher waiting in the halls for a bed because there's just no beds. And they think, if I go with the ambulance, I'm going to get seen faster. That's
not true.
That's absolutely not true.
Like, is it a little true, or is there like a truth to it?
No.
Like you wouldn't even say like they say that because of this. Like it's just straight up like
it's just straight up not true.
Really?
The ER is going to triage everybody.
So they don't have a room for you already?
No, they don't have rooms ready for us at all. I've waited at hospitals for up to like 3 hours with the patient on a bed on our stretcher waiting for a bed, because they're either just overloaded or there's just other critical calls that are taking priority.
Wow.
So
unless it's like a level like trauma, right? Unless it's like a priority.
It goes based upon the triage.
But level. Everyone's gonna get triaged the same.
Yeah.
Ambulance or not. Like if I walked in with a gunshot wound or in an ambulance, I'm gonna get the exact same priority speed.
Oh yeah. They're gonna
Okay.
look at you and be like, "This guy's come on, we need to get you in quick."
Yeah.
Definitely.
And the guy with the stomach ache that called 911 because he could get faster, he's still waiting in the hallway.
Exactly.
Okay, that's good to know because like for all of us that do that, hopefully we don't. But for all of us that do that, like it's not gonna make a difference.
I think it's just a misconception,
and you're gonna get a bill on top of it, right?
I think it's just a misconception. There's times where people want to go to the hospital, and not that it's wrong for them to want to go to the hospital, but I've seen it where it's like your vitals are stable, you're normal. You want to go onto the ambulance and get a $2,000 bill? By all means.
You ever asked them that?
I don't, right?
No,
I think that's kind of rude.
You think it?
Yeah, but I definitely think it. And it's just like, you want to do that? Then fine. I'll offer to them and I'll like kind of insinuate, you can also go to the hospital in your own vehicle if you have a family member take you, and they'll see you just the same. But they don't understand that part. They're like, no, I'm going to go in the ambulance, and they'll see me faster in the ambulance.
Yeah.
All right, cool. You want to add that bill on top? Let's do it.
Okay.
I'm working till 8 in the morning either way, so I'll take you right now.
That's true.
It doesn't matter to me.
And it locks you up too, right? So now you can't answer other calls because I got you.
But yeah, that's definitely one of the PR things that, we want the public to know, is that you are basically putting that ambulance out of service for a real call that could be dropping.
Literally is what you're doing.
Exactly. And if it's something that maybe isn't that major, I get it. It's an emergency to you, but in the eyes of paramedics, RNs, and doctors, that's not an emergency to us. That's something that, oh, my stomach hurts. How long has it been hurting for? Oh, like 3 months. And you haven't gone to see your doctor? Like, what do you think they're going to do for you at the hospital right now that they're
What's
not going
to change in 20 minutes?
Exactly.
Yeah.
But people don't always understand that. So
and that's not anybody's fault either.
Exactly. Yeah. And it's just one of those things that we want to try and get out there more. Leave the ambulance for like critical, real emergencies.
Yeah, that's good. Thank you for telling us that, man. Because like, that's true. I hadn't even realized that either. Like you're removing like a a critical public service, like an individual is single-handedly removing the option or like the ability of someone to get their life saved because like they wanted selfishly. Hopefully that's not happening a lot, but I'm sure it has.
It has happened in the past, but thankfully we have multiple units, at least in the city that I work for. We have multiple units that run around, and then we have really good contracts with other agencies that work in the neighboring departments. So we'll help each other out. Like if they're out of service, of like all their units are out, they'll call us. Hey, you think you can send a unit over here? We have an emergency going on. For sure, we'll go out there. And then the day that we need it, we'll call them, and we call that mutual aid. So
cool.
We help out the neighboring cities as much as we can, because
you have to.
At the end of the day, we're all in the same boat, and we got to try and help each other out. So it is not super common for that situation to happen where you really needed someone there, but it can definitely happen.
One thing that we do, like on all our episodes, like we always try to make sure that we learn something out of it. So I'm gonna ask you something.
Okay.
Okay, so I have a cut, right? I have a cut right here.
All right.
Where do I apply the tourniquet or the pressure?
So I'm actually a stop the bleed instructor and a CPR instructor.
I didn't know that. Yeah. I should have, because it was on his paper that he gave me. I'm sure it was. But
I'm actually, and I do training with the alert as well. That's the I can't remember the acronym. It's a really long acronym. But basically, I teach first responders, police officers, and teachers how to do all like that life-saving.
Teachers too?
Teachers too, yeah.
Can't forget them.
No, definitely. Teachers to me are probably one of the most important jobs in the world, man.
Me too, bro. Literally, that's the future of...
They do so much, and sometimes they're taken for granted.
And they do everything, dude. They are the nurse too, and they are like the social worker, and they're the cop.
They're
the mom and the dad.
They're the true first responders. I just had a presentation at a school a while back, and it was during Teacher Appreciation Week. So as they were introducing me, I kind of put that in there as well. I was like, by the way, I want to shout out to all the teachers, because you all are the true first responders. When a tragedy happens or anything happens, y'all are going to call. It's still going to take me at least 5 to 8 minutes to get there. And so during that time, if I can teach you what to do to save somebody's life, then it goes a long way.
That's true. That's a good one, man. So okay,
back to your question.
So I have a cut in the middle of my forearm.
Okay.
And it's bleeding, right?
Like profusely?
We'll say it is, right? It's pumping. So that's
right.
probably arterial.
Okay.
But anyway, who cares about that? I'm bleeding right now, right? So I'm bleeding. Where should I put the tourniquet that I just made out of a tie?
Okay, so if you have a tourniquet, you're going to want to put it at least 2 to 3 inches away from the cut. But what I like to
Above or
teach,
below?
above.
Above. So
Yeah.
my cut is in the middle of my forearm. I put the tourniquet above, which means like closer to the shoulder.
Closer to the shoulder, yeah.
Okay. So if it's on the middle of my leg, closer to my body.
Yeah. But what I like to teach is just go high and tight. That's what I tell everybody.
Okay.
It'll cover all your bases.
No matter where it is.
Yeah, no matter where it is.
So if it's on my arm, go high.
Mm-hmm.
Okay.
You only have one artery that runs through your arm, which is your brachial artery, and it starts at the top. So if you go up to the top, and what I mean is, up here, don't go on top of your shoulder because now you're actually on the bone, but you want in that, where that tissue is, the muscle, you'll apply it there, and you want to do it until you stop feeling a pulse. That means you've cut off blood circulation down there. You won't bleed out. So you're going to put it high
Super
and tight. Yeah, and it hurts. I'm telling you, I teach stop the bleed. And that's like one of the biggest things that I have to get across to my students. Tourniquets hurt, like ugly. Like it's not a comfy feeling whatsoever. It's super uncomfortable, but it is a life-saving measure. If you can stop that bleed there, then that patient will live on you. They might lose that arm.
You'd rather make them hurt than bleed out, right?
Exactly.
Pain doesn't kill, but bleeding does.
Exactly.
So you never put it under.
Yeah, no, never under. You always want to go above. So that's why I teach high and tight. That'll cover all your bases.
Yeah.
You have 3-4 cuts. You go up here, you're good. Same thing for your legs. As high as you can up into that little groin area, and then tighten down.
Okay, cool. And I could do that. Like I can make a makeshift, right? Like with a tie or a shirt.
You could.
Is it better to do that or to cover it?
Well, it depends on what type of bleed it is. That's why I asked you what type of, what is it bleeding profusely, or what type of bleed is it? If it's an arterial bleed where it's like
pumping,
spraying and pumping,
you can see the heartbeat.
Definitely, you're gonna need a tourniquet. If it's a slow bleed where it's just kind of oozing out, direct pressure will do good. So you'll just get gauze or a t-shirt if you have it, put it over, and you want to hold it down, pretty firmly for at least 5 minutes.
So spraying, always tourniquet.
Yeah.
Okay, and that also means, by the way, guys, if it's spraying, that means it's deeper because your arteries are deeper. Mm-hmm. And there's only one, so it's the brachial too, which is bad if it's on your arm. But anyway, okay, cool. So we got to remember always to
tourniquet above. Yeah.
How would you say high and dry? High and tight.
High and tight.
High and dry. That's something else. Never mind.
High and tight. That's what I teach. You want to put it high and tight. There's a lot of other different techniques like packing. I've had to do that before. For
deep cuts.
Yeah. So
you've had to do the packing?
Mm-hmm. It just depends where the wound is. There's certain areas you can pack and there's certain areas that you can't.
Yeah.
I've seen people try to like pack like chest wounds, but that's funny because, this whole area is a cavity. So you can literally be packing and packing and packing forever. And packing. You'll pretty much go forever.
Yeah, there's no cut in there, right?
It's a balloon. It's an empty cavity. So it'll just keep going. You'll be causing more issues on the inside, really.
That's good to know, man.
There's a lot of information when it comes to paramedicine, man. There is a lot of information, but it's fun. I like it. It's just another part of the job that I fell in love with.
Last question.
All right.
One more for family, right? Because now I'm the family and I'm seeing my family's freaking, like something's happening. I'm freaking out. Mm-hmm. How do I stay calm?
The family?
So my brother's on the floor. He's choking.
Okay.
How do I chill out?
That's hard to.
Like, what can I do to like not freak out in an emergency situation? Because that matters. Because I might have to stop his bleed, and I'm freaking out, then I might not be able to. Like, how do you help people to calm down?
That's hard. There's some people who can, some people who can't. I've seen it all across. I've seen people who just, they keep their cool, they keep their composure, and there's just some people who just, it's really
freak
hard
out
for them. Yeah, depends on how emotional they are and stuff like that. The best thing I can say is just, breathe. Count to 10 and breathe and count to 10 between each breath. Kind of like force yourself to kind of stay calm and, remember the situation. If it's your loved one, you want to do everything you can for them. You freaking out isn't going to help them, unfortunately. So
remember that. Breathe.
Yeah, breathe. That was probably the biggest thing. People they go into a panic and it's hard. It's tough. It really is tough. But yeah, just try to remain calm as best as you can. Breathe in through your mouth and out through your nose, or the other way around. I don't remember which way it is.
But breathe.
But breathe. Remember to breathe. Like if you can at least do that, then it should help you to like kind of settle where you need to be in.
Okay.
But for the most part, people tend to like know what to do, or they tend to stay calm, especially if they're by themselves. I kind of
Mm.
seen it where if there's more people, then they freak out because there's like a subconscious idea of
Oh,
like, oh, there's other people around me.
I
So
can afford to freak out.
exactly. Versus when you're by yourself, okay, you know what? There's nobody else.
Just me.
I better do something.
Yeah,
Yeah.
that's a whole thing in psychology.
Yeah.
I think it's called the bystander effect or something like that. Like you just assume that someone else can take over. So
Exactly.
your body's like, all right, you can
Yeah.
scream, like you
No,
can. But then that
definitely.
makes it worse because if you're, but I mean, some people can't help it. So like,
Yeah. But
it's a tough one
if you are that person who can stay calm and you do have other people around you,
that are freaking out.
then you can be the person to kind of like calm everybody down and just give them orders. Hey, I need you to go call 911. I need you to go and do this. I need you to
Mm,
go and do that. When people get a specific order to do something, it kind of like sets them or resets
do
their
that.
brain. Okay, I
Yeah.
got to go do that. And it kind of will bring the tension of the situation down a little bit.
Okay, cool, cool. So the first session, I asked you what something that firefighting has taught you, and now I'm gonna switch it up, but I'm gonna throw you in the fire though. Oh,
Okay.
that was no pun intended. Honestly, I didn't mean to do that.
That was good.
So
I was like, I either planned that or
no,
that's
I did
completely
not.
unintentional.
I did not. But I'm gonna ask you something because this might be interesting to the people who live in your world. So Rick is a both a paramedic and a firefighter, right? I gotta ask you, man.
Oh no. I already know where it's going. Which one do I like better?
Which is the best? Are you team paramedic or team EMS or team fire, man? What's the better job? Because there's people out there that are like trying to decide what they want to do,
Yeah.
and then just the people like, nah, man, like it's all about fire. Or is it all about fire? Or is it all about the EMS? Which
This
do you prefer?
this profession is changing and it is evolving. Up north, a majority of the fire departments are all fire based EMS, meaning all of them do fire EMS together. On the trucks, you'll see San Antonio Fire EMS. On an ambulance, you'll see San Antonio Fire EMS. New York Fire Department, that's fire EMS as well. They do both.
Really?
Yeah. So it is it's not to say, but the Valley is behind in times. You know, Houston Fire EMS.
I think with everything that's the case.
Yeah, unfortunately, right? But it's one of the trends. So I can't say that there's one that I like better or more or which one is better. I think as an individual, to me, it matters that I can do both jobs proficiently. If I can do both, then I can wear two badges on my, my shoulder saying I can do both these jobs. And not only can I do both of them, I can do both of them, proficiently and efficiently. That way, it makes you a more marketable person, especially if someone who's in this, profession, you can go to someone and be like, oh, I need this fire put out. All right, yeah, let's, go to this person. He can do it. Oh, but now this is going on within a medical emergency. You can go to that same person. Yeah, I know he can do it. Versus the guy that can say, oh, I only do this. Oh, I only do fire. If you can do both, you've just made yourself a jack of all trades. So that's the, I guess, the advice or the team that I would say. I've fallen into it where it's both, man. This job, if you can do both, you're not only providing a better service for your city, for the citizens that live in your city, but you as an individual, you're providing you're putting yourself at a higher level of expectation for yourself. You know what? I can do this, but I know I could also do this. And then you're doing both and you're flying at a different level. Not to say that, paramedics are better than firefighters or firefighters are better than paramedics or fire paramedics are better than each of the other. But it's just as a self-individual thing. If you can hold yourself to that standard, why not? You're only doing yourself better because you're gaining more knowledge, more experience, and then you're opening up that ability to help people in more than one facet.
Okay, that's true. That's true. I like what you said about being more marketable because really what that means, like to everyone else, is that like you're able to help that much more,
Exactly.
right? So
Yeah, it definitely is, man. One of the things that I love about this job is the ability to be empathetic with people, especially in emergency medicine. Going to see someone on their worst day and then being able to make it just a little bit better. That's one of the biggest things that I try to push for, is my patient bedside manner. That's the biggest thing. And I think that unfortunately, a lot of private EMS companies have lost that ability to do that. And there's lots of reasons for it. And that's not to say all of them do. But from what I've seen over the course of, the last 10 years, you pick up on certain things. And private EMS it's a money making business is what it is. It's like the hospitals. They're there to make money.
At the end of the day,
At the end of the day,
it's a business.
It's a business. It is. And so they run it like a business. When you have a fire-based EMS system that comes from a municipality in the city, it's run a little bit different. When we go for fires, we're not getting paid for like, oh, how many fires did you put out? No one cares. It's different. You know what I mean?
It's a true service.
It's a true service that you're giving. And so when you can blend that in now with EMS, and it's not about, oh, well, how many calls are you taking? Are we making money back?
Volume.
Exactly. It's more about, all right, are you providing a good service to your, patients, to the community? Are you out there helping them? Then the quality of care that you give them, you notice that it's more empathetic. I'm also a field training officer for new medics that come in. And that's one of the biggest things I teach them is you got to be able to have really good patient communication. Like, I get it. You could be 4 a.m, you're tired, you've had a long day dealing with a bunch of silly calls, and here comes another silly call. That doesn't give you the right to be short with them. It doesn't give you the right to be, just like, all right, get on, whatever, let's go. You can't treat them that way. Because at the end of the day, in their eyes, it's an emergency and they need help. So you have to be able to treat them with respect and dignity and get them to the hospital. If you can, make a rapport with that elderly lady, in the nursing home, even if they have Alzheimer's or dementia, they're not going to remember everything. But if you can make them laugh and feel comfortable, why not? You're making that whole experience just a little bit better.
And you have to do that anyway, so you might as well enjoy it, right? Like, you might as well, like, you can either be cold or empathetic, but you still have to do that job no matter what. You might as well, like, you're gonna do it anyway, right? You might as well
get some, sense of,
because it helps you too.
Yeah, exactly.
Like, you enjoy it. You enjoy your life is a lot easier when you're not like grumpy Squidward.
Exactly.
Right? Like, it's true, man.
Exactly. And there are burnt out medics out there, unfortunately, but
that's not their fault either.
And no, it isn't. You go through a lot, you see a lot, and so it does take its toll. But if you can try to remember to do those things, I think it extends the longevity of how much you'll enjoy the job.
Exactly, yeah, because you're doing it. You might as well enjoy it, right?
Exactly.
Yeah, that's so true, man. Like, I think we can find like our version of that, like in anything that we do, because that takes like a little bit of the edge off, right?
Exactly, it does.
And it doesn't even that doesn't solve the problem, but it makes it easier to deal with everything that's coming.
Exactly.
That's so cool, man.
Yeah, it's just little things like that you got to keep in mind in this job. But I doing this already for so long that I like it. I've come to know how to do it.
Hey, honestly, thank you for this conversation, man, because I think we learned a lot, like from literally face value, high and tight, not dry, but even just like, I mean, just the lessons, man. Like have some empathy, right, for people. I mean, like, we can either, if we can help. I think that's a power that we have, right? Like, to help someone. There's beauty in that, because like we don't have to like change anyone's life, but if you can and you do, like, that's gonna stay with them forever.
I think it can be applied anywhere, man, in any job. It doesn't have to even be in healthcare. Just empathy in general, when we're helping somebody else out, if it's a service job, if it's, whatever it is, have empathy for people. I think that's one of the traits that unfortunately the world is losing. And so if people can at least try to remember to be somewhat empathetic in their job, I'm not saying you have to go 100 million miles out of your way, but even just, certain comments or certain reactions, the way we treat people, it makes a big difference, man. It really does.
All right, man. Well, thanks for being here, by the way. This was recorded during EMS week, so happy EMS week to everybody out there who works on those front lines. Happy EMS week, Mr. Rick. Hopefully the hospitals are giving you stuff to celebrate it.
We don't do it. We don't do it for the stuff.
For the incentives.
For the incentives.
The happy EMS week, man. We got to remember, guys, that does exist, right? Apparently it's in at the end of May.
Yeah.
So we got to remember that one, man. Whenever you see a paramedic or EMS team out there.
May 4th is actually International Firefighters Day.
May 4th, International Firefighters Day?
Yes, it coincides with International Star Wars Day.
Yeah, May the 4th be with you.
Yeah, okay. Just so you know. Yeah.
May the fire be with you. Okay. Or hopefully not, right? But,
yeah, definitely.
All right, man. Well,
I appreciate
thanks
it,
for being here, bro.
It was awesome.
Yeah. Have a good day, everybody. Say no to drugs.